How common would you say is heart disease?
Heart disease is the #1 killer. Someone in this country has a heart attack every 33 seconds.
Dr. Ovadia is a heart surgeon who is focused on preventing patients from getting into his operating table.
Best-selling author and international speaker.
About 650,000 people die from heart disease every year. That's about 1 out of every 4 people that dies.
Cardio is an unreliable tactic for fat loss. Why is that?
It's ineffective for fat loss for a number of reasons. The time that you spend doing that could be much more efficiently spent and have much more benefit to you if you're doing resistance training. We have bought into the narrative that cholesterol is the cause of heart disease, and it's not. When you look at cholesterol levels on a population basis, they are lower than they have ever been, yet heart disease keeps getting worse. I wasn't just obese, I was what we call morbidly obese. I was headed for my own operating table, so to speak. What we all have learned throughout our lives, eat less, move more. Both the COVID vaccine and the COVID virus itself can lead to inflammation in the heart. The cancer doctor is focused on the cancer, right? And the neurologist is focused on the Alzheimer's disease. And because they're not looking at that whole picture, right, they miss the connection that all of these things come from the same root cause. You can definitely notice a difference in the fat layer that's on the surface of the heart, what we call the epicardial fat.
Dr. Ovadia, tell me the mission you're on and why you chose it in the first place.
Yeah, great to be here with you. The mission that I am on is to change the narrative around heart disease. Heart disease is the #1 killer in the U.S., in the world, has been that way for over 70 years now. And I, early in my career, decided to focus on this problem as a heart surgeon. And what I've come to realize is that we are doing a very lousy job in the battle against heart disease. So over the past decade or so, I've shifted my focus, and I now want to prevent the heart attacks, prevent the need for heart surgery. And I do believe that the vast majority of heart disease is preventable. And I will know that I've succeeded in my mission when heart disease is no longer the #1 killer.
How common would you say is heart disease right now in the United States?
Yeah, so it's incredibly common. About 650,000 people die from heart disease every year. That's about 1 out of every 4 people that dies. Someone in this country has a heart attack every 33 seconds. And while we've gotten better at keeping people alive, making sure that they survive their heart attack, for instance, we have completely failed in the prevention of heart disease. And every year, heart disease becomes more and more common. And that's what we need to change ultimately.
What can be done for us, and that you mentioned in your book, to lower that incidence? Because I believe it's really easy. I think it's especially about food and many other lifestyle changes. What are specifically those that are the most important things that we can do to lower our chances of having a heart attack and not being on your operating table?
Yeah, so this really comes down to first principles, fundamental thinking. If we don't know what causes a problem, causes a disease, we have no real hope in preventing it. And the problem around heart disease is we have become distracted. We have bought into the narrative that cholesterol is the cause of heart disease, and it's not. It might be a contributor, it plays a role in the process, but it's clearly not the cause of heart disease. And therefore, by focusing only on lowering cholesterol, managing cholesterol, it's been very ineffective. So we need to get back to what the true root cause or root causes of heart disease are. And this comes down to insulin resistance and inflammation. And only when we address those things, and you're right, that can largely be addressed by things like diet and lifestyle. But we're going to need to shift the focus, the conversation around heart disease, to those issues and to addressing those issues. And that's what's going to allow us to make real progress against heart disease.
So you mentioned that cholesterol is not the main boogeyman as we think it is for heart disease. As many people have heard, you should lower your LDL, you should increase your HDL. Increase your HDL, yeah, fine. But lower your LDL because it's the bad cholesterol that clogs your arteries. Why is it not the big boogeyman as we think it is? It was on the 50s, on the 60s.
Yeah, so first of all, we need to understand that the science, the studies that linked LDL cholesterol, or at first total cholesterol, with heart disease show pretty weak associations, right? And, many people in your audience might be familiar with the concept of, the difference between associations and causation.
Yeah.
And so, one of the ways that we separate that out, right, when we see things that look like they're associated, we talk about the strength of the association. And when you look at something like LDL cholesterol, total cholesterol, you see very weak associations. You see increases in risk of, 1.4, 1.5x, whereas things that are truly causal, right? And the classic example of this is smoking and lung disease, right? You see 10, 20x increases in lung cancer in people who smoke. So that alone should give us some indication, right, that LDL isn't the true problem. Incidentally, and we'll talk more about this, right, when you look at insulin resistance in heart disease, you do see 5x, 6x, 7x increases, which tells you you're getting closer to the true root causes. Now, I think the problem that came along with cholesterol, there are two things. Number one is heart disease is and was a massive problem, right? And you go back to the 1940s, the 1950s, when the rates were exploding and people didn't know why. And, it looked like this cholesterol had something to do with it. And there was a lot of enthusiasm that this was going to be the solution to the problem. And, people got on board. And then that got compounded, right, when we now had medications that were released, statins being the first ones, or the most popular ones at least, that could lower cholesterol. So now you had what looked like it was part of the process, an association. We had a way to treat it, right? And, clinicians, doctors, they want to help, they want to treat things. Mm-hmm. And so this sort of became a runaway train. But here we are now 40, 50 years into that belief that cholesterol is the main cause of heart disease. We've done a great job, at treating cholesterol. When you look at cholesterol levels on a population basis, they are lower than they have ever been, yet heart disease keeps getting worse. Mm-hmm. So now it's time to step back and say, maybe we got something wrong. But again, we're dealing with an institutional problem, and the approach is just, well, it's not working because we're not doing it hard enough, right? We need to get cholesterol levels even lower. We need to start earlier. And it's just sort of, like I said, this runaway train that at the institutional level, it can't be, kind of step back and have that reflection of maybe cholesterol isn't the problem to start with.
Uh-huh. And I totally agree with you. Our cholesterol has been the lowest as ever. We've been using more statins than ever, and we still have heart disease growing, and growing. So maybe it is something else. And so I think the population is a little confused. I think they do not know because many different experts say different things. Some say that for you need to lower cholesterol, you need to avoid saturated fat and all of that. And some others say that you actually should reduce the amount of carbohydrates that you eat, focus on insulin resistance. So what markers should you really know that you are metabolically unhealthy? And also, what number should we seek for?
Yeah, so I always start with the most basic markers of metabolic health, right? And there are 5 of them that are essential for people to know. The first 2, you don't need blood work. You probably don't even need to go to your doctor for. So we have your waist circumference, right? All you need is a tape measure at the level of your belly button, best to do it first thing in the morning. And if you're a man, your goal is for that to be less than 40 inches. If you're a woman, you want it to be less than 35 inches. The second metric we look at is blood pressure. And again, you can measure this at home. You can order a blood pressure cuff. You can go to almost every pharmacy and grocery store these days, and they have a little kiosk to check it. Or the vast majority of the time when you go to the doctor's office, they're going to check it for you. And your goal is for your blood pressure to be less than 130 over 85 without the use of medication. If you've already been started on medication because of high blood pressure, it's an indicator that you may not be metabolically healthy. The other 3 measures are going to come from some basic blood work. And again, the vast majority of doctors get this blood work done as part of your sort of routine annual. The problem is they don't look at it in the context of these metabolic health metrics. So we have your fasting blood glucose level. You want that to be less than 100 milligrams per deciliter. Again, without the use of medication. If you've been diagnosed with type 2 diabetes, if you've been started on medication for high blood sugar, you are metabolically unhealthy. Some people, instead of the fasting glucose, will look at the hemoglobin A1C, which gives you an idea of your average blood sugar over about a 3-month period. And if you're looking at that, you want it to be less than 5.7%. And then we do look at cholesterol numbers, but we don't look at that LDL. We don't look at that total cholesterol that most doctors are focused on. We look at the HDL cholesterol that you mentioned earlier. And, this is something that we want a higher amount of, right? And this sometimes confuses people because they hear cholesterol, they think lower, but HDL cholesterol, you want it to be higher. Specifically, if you're a man, you want it to be over 40 milligrams per deciliter. If you're a woman, you want it to be over 50 milligrams per deciliter. And the last measure we're going to look at is on that cholesterol panel. It's a number called your triglyceride level. It's a little bit different than cholesterol, but we kind of measure it together with it. And this you do want to be lower. And specifically, you want your triglycerides to be less than 150 milligrams per deciliter. So you put that all together. We have 5 metrics. If 3 or more of those are not in the healthy ranges that I mentioned, you are diagnosed with what we call the metabolic syndrome. And it means that you are insulin resistant and you're at high risk for things like heart disease, cancer, Alzheimer's disease, chronic kidney disease. You can go down and down the list. Almost all of the top 10 causes of death and the chronic diseases that we struggle with in the United States and worldwide are associated with the metabolic syndrome. So that's a great place to start. You can get a lot more in depth, and we'll maybe talk about some of that as we go along. But if people just start there, it's going to be a huge improvement because the vast majority of people don't know these numbers or haven't put them all together in this context of figuring out your metabolic health.
Is that solely preventable by diet? Can we make those markers in a better range by diet within itself?
So I think diet is the most powerful tool that we have to focus on. It may not be everything. It may not be the only piece of the puzzle, but I think it's the most important one. And if you're not getting the diet right, some of the other things that come into play, like getting good sleep, getting enough activity, managing your stress, it's going to be very hard to overcome the poor diet. So I always start with, let's get the diet right. Let's use the diet as one of the tools to improve your metabolic health, reverse insulin resistance, and then we can continue to build upon that with the other lifestyle stuff that we talk about.
So what would you say, based on your clinical experience, what is the perfect diet for you to reverse those metabolic problems?
Yeah, so the perfect diet is the one that's going to reverse those metabolic problems, right? And I always tell people there's no one right diet for everyone. First of all, the most important thing about choosing your dietary strategy is you have to be able to do it. You have to be able to stick to it. It needs to fit within your daily life. Now, the general framework is the more metabolically unhealthy you are to start with, the lower your carbohydrate intake needs to be. So low-carb diets are extremely effective at reversing insulin resistance and the metabolic syndrome. And so that's usually the direction that I point most people in. The second principle that I think is important is your body needs to be able to absorb the nutrients that you're eating. And the foods that you're eating should be dense in nutrients and bioavailable, we call it. And this really leads us to animal foods first and foremost. Animal proteins combined with the fat that comes with it are the foods that we primarily evolved eating as human beings. For the millions and millions of years of our existence as human beings, our diet was primarily animal-based. And grains, carbohydrates, these things, fruits, they only started to come in little amounts. And it's only very recently, right? It's a tiny dot in time, the past, couple of hundred years, that we've had these things in abundance. And it's an even shorter period of time, right? The last 50 to 100 years that we've had them year-round, right? That we could, move them between climates, right? So that they were always available to us. So we need to keep that in mind, right? Our bodies evolved primarily on animal proteins, animal fats. Those are the most nutrient-dense, the most bioavailable form of the nutrients to us. And that's what we should really base our diet on.
That's what I talk with most of the people that I know, because they know I am someone that really cares about my health, etc. And they always ask me, because this is something that many people focus about, which is losing weight, being in shape, etc. Because that's a sign of overall health, obviously. I'm not talking about the extreme, getting to very, very low body fat, but actually be healthy in general. And what I talk to them is what I've talked about called the farmhouse diet, in which the first principle, as you mentioned a lot in your book actually, is just eating foods that can be processed, collected, and done in the farmhouse, in which we've been eating for thousands of years. Grains were present, yes, but at the very end. And also within that eating real food, there are strategies for you. Maybe you should eat less carbohydrates. You should have a low carb diet. Maybe you can eat more because you're more tolerable. You're someone that's very, very active within the day. You're an athlete, for example. That might help you, even though you've talked about also being keto and also that being extremely helpful for athletes too. Some people react in different ways, and maybe eating with carbohydrates, people react better. So just by that, if you eat real food, you're going to exclude, I would say, 90% of your problems. And then you just need to dial in, obviously, on your sleep, on your stress, on your activity, and all of that. But Dr. Ovadia, I would like to mention something else. So at the very start of your book, you mentioned you were 40 years old and you described yourself as being obese. And you're already a doctor. So what was the turning point from that?
Yeah, and I wasn't just obese. I was what we call morbidly obese, and I was pre-diabetic. And I came to this realization that as a heart surgeon, I was headed for my own operating table, so to speak. I was, following that same path that so many of my patients had followed. And I also came to the important realization that I didn't know how to fix it. Right? What I had been taught in school, what we all have learned throughout our lives, eat less, move more, eat a low-fat diet, follow the food pyramid, it wasn't working for me. It wasn't working for my patients. And I just recognized that there needs to be a different way. There must be something out there, right? And I started asking some different questions and maybe, opened myself to some, what we would say is alternative information, right, outside the mainstream of medicine. And thankfully, I came to learn about the harms of sugar and the benefits of low carbohydrate diets. And I tried it for myself. And I had, great success, lost, 100 pounds. More importantly, was able to maintain it, right? Because in the past, I'd been able to lose some weight, doing the sort of calorie restriction, but I could never maintain it.
Unsustainable.
Unsustainable. And that's the truth for almost everyone, because that, isn't sustainable ultimately over the long term. So once I saw the success for myself, and then I started talking to some friends and family about it, and they, had similar results. And then I was able to, find other practitioners who were doing this and talking about it, and, really get into why it works so well, understand the science. And ultimately, and maybe a little bit tangentially, right, I then came to recognize that this was the root problem of heart disease itself, right? I was focused on obesity at first and, maybe the pre-diabetes that I had. And I didn't immediately make that connection to heart disease. But as I learned more and more, I realized that, this is the root cause of heart disease, the metabolic problems that come with obesity and are represented by the diabetes and the pre-diabetes. That is the real cause of heart disease, and that is what really caused me to refocus my career and, go on this mission to educate people about how we can finally conquer heart disease.
Do you think the approach from allopathic medicine made you think that obesity was one thing and heart disease was another? Because that's very, very crucial to understand. Because I think what most doctors are missing, not to criticize all of them, not to say that they are people who do not care about our health. They do really care about our health. I don't think they go through this path, going for med school, studying hours and hours in their desk, alone by himself, with no motivation besides himself thinking of delayed gratification about practicing and helping other people. But do you think we should shift more about the allopathic medicine to a more holistic approach? And how can we implement that to medical school? Because I think this is really, really important, not just for me, but all future doctors that has been given that idea that we should separate things, just the cardiothoracic system, just the respiratory system, just the lymphatic system, etc.
Yeah, it's certainly a problem, right, that we've become so siloed and so specialized because we do miss those connections, right? The heart doctor is only focused on the heart disease. And the cancer doctor is focused on the cancer, right? And the neurologist is focused on the Alzheimer's disease. And because they're not looking at that whole picture, right, they miss the connection that all of these things come from the same root cause. And if we address that root cause, that, becomes so much more powerful, right? And, getting back to the cholesterol discussion, right? Even if we accept the cholesterol narrative and heart disease as it is, right? No one claims that, managing your cholesterol is going to lower your risk of cancer, for instance, or, can lower your risk of Alzheimer's disease or chronic kidney disease. Insulin resistance, when we reverse it, it clearly lowers the risk of all of those things and so much more.
Yeah.
Right? So I look at that as a physician and I just say, okay, this is a much more powerful tool. And the unfortunate thing is most physicians don't learn about this, right? As physicians, we are trained to diagnose and treat the end diagnosis, right? The heart disease, the cancer, the, chronic kidney disease, whatever it might be. we're not trained to think about the root causes and how to manage those. Now, I am optimistic. I do see the conversation shifting. I do see lots of medical students and early stage doctors, early career doctors who are thinking about this. And at some level, right, doctors are recognizing the futility of what they are doing, right? We talk about shortages of doctors. We talk about the burnout that doctors are experiencing. And ultimately, what that comes down to for me, I think, is that doctors, like you said, we are motivated to help people. And we're not seeing the people that we're trying to help actually get better. And that becomes very defeating. So that is why I am optimistic that this is going to take hold, that this is going to be more emphasized. And then it just becomes a matter of, we have to be realistic and we have to realize that there are very entrenched institutions, right, that don't necessarily want doctors in the healthcare system focused on this stuff. They would rather continue with, the pharmaceuticals that they're making plenty of money off of, the surgeries that they're making plenty of money off of. The whole system, right, is geared towards taking care of sick people. It's not geared towards keeping people from getting sick in the first place.
There was a very important thing that I think many doctors has a different approach towards that. Even when they're on the holistic space, treating metabolic disease, not just an allopathic problem, in which, where do you draw the line between pharmaceutical drugs like statins and many others from actually treating using a more metabolic approach, focusing on diet, etc.?
Yeah, pharmaceuticals are a tool, right? And I want to be clear, right? They have helped immensely with our overall health. But they really should be thought of as short-term tools, right? We shouldn't be chronically on these medications. It's very rare instances, for instance, that you might have a genetic issue that prevents you from making some key thing, right, that we can replace pharmaceutically, and therefore you're going to need lifelong. The reality is that most of these conditions that we treat with pharmaceuticals, and especially these lifelong chronic medications, they have an underlying root cause that can be corrected with diet and lifestyle. And there certainly can be a role for using those pharmaceuticals short term, right, while you address the underlying issues. But doctors have been misguided into thinking that the pharmaceutical is the solution to the problem, and it's not. At best, it's a Band-Aid, right? It's kind of delaying maybe some of the problems that we see related to these disease processes, but it's not correcting the underlying problem. And that's what doctors need to focus on. And again, this is going to take a shift in the entire system, our educational system, and our reimbursement system around how doctors are paid, how hospitals are paid. All of this needs to really shift. But, again, we're sort of being forced down that route, right? This is another reason that I am optimistic in a way that I don't really want to be optimistic because of this, but the reality is that the system is on the verge of collapse. We can't sustain our current healthcare system. We can't afford it financially. We can't continue to absorb the disability, right, that throughout our population. We look at things like the military can't recruit enough healthy people, right, that can meet like the weight guidelines and the physical performance guidelines that are necessary. And so these are big societal issues that we're going to have to tackle. And, again, it all leads back to a different approach, this metabolic diet and lifestyle centric approach, as the ultimate solution. And thankfully, again, we're starting to see that come into the conversation at the political levels, and more practitioners are waking up to these facts, right? I go to conferences and I speak at conferences that are centered on metabolic health, and I see more and more practitioners from all sorts of different specialties that are becoming interested in this, realizing the power of this. And the people, the patients, the people that are there also recognizing it. That's how we're ultimately going to kind of take back control of the medical system and really make the changes that are needed.
I totally agree, because you also mentioned that on your book, that hospitals, for example, they should follow the dietary guidelines imposed by CDC and FDA in order for them to get their money towards that. And imagine they're feeding grains, processed carbohydrates to people that are actually, for example, with cancer, in which we know that's a metabolic problem. And if you give them even more sugar, that's going to stimulate the growth and angiogenesis of the tumor itself. Same thing with heart disease, for example. You mentioned the case that you did a surgery on, you did a heart surgery on someone who was in a hospital, and then you saw what they were eating, and his blood sugar was through the roof. That's one of the reasons about that. So I think that is a really big problem and should be changed in the United States. And I really think it's a really good thing that our politics are actually getting involved in this now, because we can deal with this. If we continue this way, we're going to be even more than 60% overweight. 60% of our population now is overweight. But if we go more people will be obese, more people will be disabled to work on certain positions, and we're going to be lacking people that are physically able to do the job. That's a really big problem in the economy, I believe, and just in health in general. So we should be really addressing that. So in my hand here, I have this book called Stay Off My Operating Table from Dr. Philip Ovadia. What was your intention in writing this book?
Yeah, my intention was to all of these things that we've been talking about, right? Try and get that information in the hands and minds of the people that need it, right? The patients that are suffering from this. I realized that, as a medical practitioner, right, I can only see one patient at a time. I can only see so many patients in a day. And, while that has an amazing impact on the people that I'm seeing, right, it can't scale to those levels that we're really going to change the course of heart disease. So my hope with the book, and I'm proud to say it's been successful, right, is that it can get this information to a lot more people. And by having books, by doing podcasts like this, by utilizing, right, these amazing tools that we have today, like social media, right, it allows you to talk to people at scale. It allows you to communicate with people around the world, and that's got to be part of the solution.
I totally agree with that. And I think this empowered the population in general, empowered them for change, because I believe back in the day, they didn't have the opportunity with social media about seeing other ways of taking care of our health. For example, lowering our cholesterol was mainstream. So everyone was focused on lowering their fat intake, lowering their cholesterol, for example, lowering the amount of eggs that we consume, etc. Now, social media has actually opened our eyes in that case, because it gives power to people who actually practice medicine, not just people who stay on the table and put rules on it. Say, this is what you should do, this is what you should exclude, and that's going to make you healthy, even though they don't have a clinical experience, for example, or many other things. And I think that's a big problem. And so you're a cardiothoracic surgeon, and I believe you had to say many unfortunate news to many families, unfortunately. And what has been the most emotionally challenging day in your career?
Yeah, so, the one that I talk about, right, the opening chapter of the book, when we had a young mother come to us with just a devastating condition, what we call an aortic dissection. This is when the main blood vessel coming out from the heart, the aorta, starts to tear. And it's a life-threatening problem. And unfortunately, by the time this woman got to us, right, despite, almost 12 hours of very hard work by my team and myself in the operating room, we could not save her life. And, I had to go tell her family, right? We had to tell her children about this. And, you know, what I recognized at that moment was that it shouldn't have gotten to that point, right? She shouldn't have ended up on my operating table with that condition. The underlying conditions that lead to it, right? Many of the things we mentioned, high blood pressure, obesity, those could have been addressed earlier so it didn't come to this devastating endpoint. And that was certainly one of the sort of seminal events that convinced me that I needed to do more to prevent people like that from ending up on the operating table.
So you said it could be avoided. How old was she?
She was in her late 30s.
That's really devastating. And this is even younger than the average population that you take, correct?
Yes. Although, you know,
Wow.
one of the interesting things I've seen throughout my career, right, as a heart surgeon, and it hasn't been that long, 25 years, right, there has been a noticeable shift. The patients that I operate on are getting younger and younger. When I was doing my training, we primarily operated on 70 and 80-year-olds. We had some 60-year-olds. It was pretty rare to see a 50-year-old. Today, I routinely operate on 40-year-olds, and 30-year-olds like that woman are not that uncommon anymore. And it just shows you the devastating effects of metabolic syndrome that's occurring younger and younger, right? We have teenagers and even preteens that are diagnosed with type 2 diabetes, right? Insulin resistance and the metabolic syndrome. And that was, again, unheard of 20 or 30 years ago, right? That was a disease that occurred in your 50s and 60s. And then, you know, there's a lag. You get the type 2 diabetes and the heart disease occurs 10, 15, 20 years later. Well, if you get the type 2 diabetes as a teenager, that's how you end up a 30-year-old on a heart surgeon's table. And, you know, again, this should be completely unacceptable as a society.
I agree.
We should not allow this to happen, and yet it's happening every day.
One thing that I think many medical students need to understand and learn this, because I think this is not taught in medical school, and that would be great to hear from you about that. How do you prepare for that conversation? First, do you learn that in residency? And also, how did you prepare for that conversation? How do you prepare for that conversation in general?
Having those difficult conversations with the patients, you mean?
So I would say, for example, I believe in medical school you're not taught about that, about talking with the patient if something happened. So how do you prepare for that conversation, especially on the first time? How was your first time saying those unfortunate news that you tried your best and unfortunately you couldn't save them?
Yeah, you know, it's one of those things that I don't know that you really can get taught in school, right? It's experience, it's, you know, just sort of life experience. You know, as a trainee during residency and stuff, you get to observe the physicians that you're working with have those conversations. And I think a lot of it is just sort of realizing, you know, seeing when the conversation goes well. And unfortunately, there are some doctors that aren't great at having those conversations, and you sort of see maybe what not to do. And ultimately, you know, this is more of one of those maybe skills that's just intrinsic as a person, right? That you're able to have conversations with people along those lines. It's never easy. You know, and unfortunately, over a long career as a heart surgeon, right, this is one of those areas, one of those specialties that no matter how good a surgeon you might be, you're still going to have those conversations. It's just the nature of the disease that we're dealing with. And like I said, you know, it is kind of a motivation that I want to have those conversations less often, right? I don't want people to end up in situations where, you know, surgery is very high risk and surgery may not go well. And that's part of my motivation, right, in doing this preventative work is, I guess you could say, maybe it's a little bit selfish in that I want to have those difficult conversations less often.
Now we've been seeing a staggering increase in the number of myocarditis incidents. So a lot of, especially young males, were having myocarditis. And your book was published in 2021, so you did not have the opportunity to talk about the potential negative effects of the vaccine and also from the COVID virus. So what is your opinion toward that staggering increase towards myocarditis, which is an inflammation of the myocardium?
Yeah, so, we certainly know mechanistically that both the COVID vaccine and the COVID virus itself can lead to inflammation in the heart. Myocarditis seems to be more common in younger people and maybe especially younger males. More broadly, there did seem to be a noticeable uptick in heart disease in general throughout the COVID pandemic. Now, I think there are a lot of competing issues here, right? We have this rising wave of metabolic disease that we've been talking about. And in a lot of ways, I think COVID it helped to unearth that, right? Or maybe make it even more apparent. And, one of the things I look at is that huge lost opportunity. Because it was obvious from the early days of COVID, right? Those first cases, if people think back coming out of China and out of Italy and then New York, that the people that were getting sickest and the people that were dying were metabolically unhealthy. And, there was a little bit of talk around this, right? But instead of saying, okay, what can we do to get more metabolically healthy, right? Let's talk about diet and lifestyle. We unfortunately did things that made the problem worse, right? We locked people in their homes. We told them to eat, comfort food, right? And
no sunlight,
no sunlight, no exercise. Everyone might remember, the gyms were closed, the playgrounds were closed, right? Crazy things that we did. And then, we introduced the vaccines, this novel therapeutic agent. And, on the one hand, I could understand, right? There was a rush to try and get this out. But on the other hand, we have to acknowledge it wasn't tested well. And something like myocarditis, which shows up in young men who weren't in the trial groups that these medications were tested upon, right? I can forgive the fact that it took a little bit of time to recognize this as a problem. I can't forgive that once the problem was apparent, it was then ignored, right? That should have been a reason to step back and say, maybe we shouldn't be giving this vaccine to people. Maybe we shouldn't be giving it to young people who, by that time, we knew were at low risk from the disease to start with, right? And again, maybe we should have just used this opportunity to say the best way to protect yourself against this pandemic was to be metabolically healthy.
And also, I feel like we created a long flu environment because, in my opinion, I think the flu is not something that really happens. I would say more about the flu is a time that people get weaker metabolically because they do not take the sun. It's colder. They eat more comfortable foods, and that's the same thing that happened during COVID, but in a long span. For about 1 year, 2 years. I remember on my sophomore year that I wouldn't go to school. I would sleep all day, not even watch the classes, for example, and just eat comfortable food. That was my routine at the time, and I believe that was the routine from the majority of people, despite the fact that people got even more stressed because many of them lost jobs, many of them had complicated conditions, I would say, financially specifically. And that also leads you to go displace that stressor towards food, for example. That's what many people do, unfortunately. And I think that's what really brought the problem from the vaccines and also, I would say, from myocarditis itself. Because that's one of the things that I talk with Dr. Neil Nathan, which is a mode expert, for example. And he mentioned that, for example, we can be contaminated by those mold toxins and other toxins in your body. However, your immune system can neutralize them. But there's a time that it gets so much that your immune system cannot deal with it, and then all of them act upon your body, and you feel weak, you feel tired, chronic fatigue, and all of that. That's the same feeling. But I'm sorry, I interrupted you. What were you going to say?
No, I mean, this is a great point, right? That when your body is battling against metabolic disease, right, and you have inflammation and your immune system is affected by this, right? You're exactly right. When other things come along, whether it be a virus or a mold toxin or some, whatever it might be, right? Your body now doesn't have the capacity to fight that like it should. And we see this over and over again, right? In a lot of ways I worry, right? Because as a clinician, it sounds kind of crazy, right? That almost every condition that we look at, it's rooted in this insulin resistance and this metabolic disease. And, I do kind of find, that I have to stop and kind of check myself and say, well, pretty much everything that people come to you with, you're talking about metabolic disease. But then it just keeps proving itself, right? Because we address that and the conditions get better. COVID was one example of that, but there were many others. And ultimately, I believe that addressing insulin resistance, addressing metabolic health, is going to have massive impacts on people's health. And it's all sorts of these end conditions that people show up with, right? We haven't talked about things like autoimmune disease, gut issues, right? Things like irritable bowel disease that all get better when you address metabolic health and you change your habits to improve that.
You mentioned over here on page 72, the cardio conundrum. You said, quote, cardio is an unreliable tactic for fat loss. Why is that?
Yeah, so we're talking about cardio exercise here.
Jogging.
And jogging or, the kind of chronic cardio. And it's ineffective for fat loss for a number of reasons. Now, that doesn't mean that it doesn't have benefits. It's just that most people think of it as a weight loss tool, as a fat loss tool. And the issues become, number one, it's just sort of inefficient, right? If you're thinking about it on a calories scale, which I'm not a big fan of, but it is one of the frameworks for talking about this. The number of calories that you can burn with cardio over time just pales in comparison to how easy it is to eat those extra calories or the calories to make up for it. And again, studies have shown this, that people that do cardio, right, they tend to do the cardio and then they get hungry and they basically eat in a way that, it's not going to contribute to long-term weight loss and fat loss. Like I said, this doesn't mean that cardio doesn't have other benefits and that cardio can't be part of the toolbox to overcome obesity ultimately, but relying on it in and of itself, which is unfortunately what most people do, right? The old adage that you can't out-exercise a bad diet is very much true. And the other thing I talk about around cardio is, the opportunity cost, right? Because the time that you spend doing that could be much more efficiently spent and have much more benefit to you if you're doing resistance training and you're building muscle, right? One of the problems with cardio is, you might burn some more calories while you're doing the cardio, but then you stop and your body goes back to its baseline state. Whereas if you're focused on building muscle tissue is going to be more metabolically active and is going to continue to burn more energy all the time, right, around the clock. So those are the two issues that I kind of talk about people with around doing cardio exercise versus other activities that they could be doing.
Yeah, you also mentioned the works from Dr. Sean Omar, in which is much more effective for you to be sprinting and walking rather than doing jogging, because that makes your body to have a bigger stimulus from catecholamines, in which is going to stimulate you to break down fat and not just glycogen and amino acids, which happen during jogging. That's a very important thing that you guys need to understand. And If you want to check out his podcast at the end of the video, when we're done here, I did a podcast with Dr. Sean Amara talking about this and how to lose visceral fat. That's a really important thing to get to know about. That's really, really important. And one thing that also Dr. Sean Amara says, and I would like to know from your experience, he says that if you have heart fat, you most likely will have heart disease. So no heart fat, no heart attack. How is that on your experience during the surgeries? Do they actually have a lot of cardiac fat?
Yeah, and Sean and I have talked about this, and of course, as a heart surgeon, I get to actually see it, hold it in my hands.
Yes.
And yes, there is a noticeable difference, for instance, in the people that I operate on for coronary artery disease, right, which is a chronic metabolic problem, versus maybe some patients that have structural valvular heart disease that is not not a metabolic chronic problem, and you can definitely notice a difference in the fat layer that's on the surface of the heart, what we call the epicardial fat. And I agree with Sean that I think the epicardial fat is another form of visceral fat. It's another marker of this disease. Now, the issue is it's not that easy to see it, right, to test for it. You can get CAT scans, you can get MRIs, but the radiologists aren't really trained to look at it.
Checking
right?
that area.
And we don't have like a standard quantification of this. So I don't use it as a metric of metabolic disease, but I certainly agree with Sean that it is a marker of it. And, I see it all the time in the operating room.
What is your take on fasting?
I think fasting can be a great tool when you're trying to reverse metabolic disease. I think fasting is, again, a process that we used to do a lot of. Right? If we remember our evolutionary history, for the vast majority of our existence, finding food and getting food on a regular basis was a big challenge. And so maybe unintentionally we did a lot of fasting. I think it's interesting that you look at every religion, right? And they all talk about fasting. Going back to these ancient wisdoms, ancient truths. And again, fasting can be a great tool for someone who's trying to overcome metabolic illness. Now, it needs to be used strategically, right? Fasting, if it's not done sort of in the right way, it can become a problem. It can be more of a stressor on your system than a benefit. If you are insulin resistant, right, it makes it harder to fast because when your insulin level is high, your body can't access body fat for energy. And this is why, people that are obese and morbidly obese, they find themselves hungry all the time because they're dependent on sugar for their energy. Sugar is a short-term, quick-burning fuel. And when they burn through the sugar that they've eaten, with whether it's eating sugar or just eating carbohydrates that get broken down into sugar, and their insulin level remains high, and they can't access their body fat, that's why they get hungry again so quickly. So oftentimes with people, the first step needs to be, we need to get you out of that sugar burning mode. We need to kind of train your body to burn fat for energy, get you into a more ketogenic metabolism. And now fasting becomes a lot easier because you can use your body fat during that fasting period. So that's how I tend to use it in the sort of algorithm as we're trying to overcome metabolic disease.
Yeah, I think every single person should be able to fast at least for 12 hours between the last meal of the day and the first meal of the day. I think we should make our bodies get used to tap into fat. I believe many people are shortening this window to 6 hours to 8 hours. They eat right before they sleep and eat right after they wake up. And I think that's a really big problem for our body to know how to burn fat effectively. And this creates a whole biochemical cascade towards it for our body to be used to, accustomed to burning just sugar because it's a simpler mechanism. Our bodies don't want to burn fat when it's easier for them to just burn through sugar. That makes it easier for them. And you also mentioned one thing that is really important, and I would like to address that. You said that, quote, doctors who become aware of the nutritional guideline deficiencies don't really have time to discuss them with their patients. Discussing lifestyle choices, metabolism, and the impact of food has on our health may save lives. But with just 15 minutes per patient, most physicians opt for the quickest fix and skip just to medicine. And I've experienced this with shadowing. I've shadowed plenty of doctors and endocrinologists, etc., because I want to do primary care. I really think it's something that I generally like, even though it can change during medical school. That changes with many people. But one thing I've seen is that doctors have 15 minutes or even less to talk with their patient. Is there anything that doctors and future doctors can do even on that situation?
Yeah, so this is one of the ways that doctors need to take back control of the healthcare system. Most doctors are working for the insurance companies, right? They're not working for the patients. And I believe that one of the changes that needs to be made is for the sort of routine, healthcare that if patients got back to paying for that directly, right, this would change that narrative. One of the things that insurance companies have done is they've devalued the doctor's time, right?
Yes.
And they've done that to such a level that the reason that doctors need to see so many patients is, doctors need to make a living, right? They need to cover the overhead of running their office, and they need to pay themselves. When the sort of unit of measurement is, how many patient visits you complete, and those are devalued so much, it just means that doctors need to churn through more and more patients, right? It's also an issue of we have so many sick people, right? And there are long waiting times to get in to see doctors. And in many specialties of medicine, there aren't enough doctors to go around. And on the one hand, you could say, okay, well, let's just make more doctors, have more people go to med school and go through training. And that is an approach. But I really look at it and say the fundamental problem isn't too few doctors. The problem is too many sick patients. So again, this brings us back to how can we get less sick patients, and focusing on metabolic disease is going to be the best way to do this and to help that system rebalance itself. But ultimately, I think doctors going back to being independent, running their own practices, being entrepreneurs, and having a more direct financial relationship with the patient without this insurance company in the middle of it will benefit both the doctor and the patient ultimately. And that's one of the other things I kind of advocate for and talk about, the way that I have structured my practice now. I have a nationwide telemedicine practice. It is a, what we call a concierge or a direct pay model. And the patients are paying me directly. We've cut the insurance company out as much as we can. And, while at first that may kind of sound offensive to people, they're like, well, I have this insurance. Why can't I use it to see you? And the answer is because the insurance company isn't interested in the type of work that we're doing here. They're not really interested in you becoming healthy in this manner. And so they don't value it. They don't pay for it. And it also, helps the patient to be more invested, right? If you can go to the doctor every time you're sick and it's not really costing you anything ultimately, you don't necessarily have that motivation to stop going to the doctor so much. For me, in this model, I always tell patients, right? I want to get you to a point that you don't need me. Right.
Yes.
And this, goes against the business model a little bit. And, but ultimately, I know that there are plenty of people out there that do need me. So I'd rather work with you, even if it's a shorter period of time, and then you don't necessarily need me as much, and we can lower the level of care that you need and lower that cost. That is how I think we're going to rebalance the system.
Yeah, that's one of the things that I talk with. I had a professor now for public health, he's also a professor from USF Morsani College of Medicine. Mm-hmm. And he mentioned that if we have healthier people, that's going to make us economically even better for insurance and also for us in general. Because first of all, if we decrease the amount of sick people, that's going to increase the amount of healthy people that are paying and contributing to the pool for the insurance, the money for the insurance, and that is going to help the insurance to actually lower the cost for those people itself. And that can, as a consequence, be lower premiums, lower deductibles, and all of that, lower copays. And that's going to be an amazing experience for everyone. But we need to get healthy in the first place. I think a healthier country is going to feel everything. To make it better is a beneficial cascade, I would say, because more people get healthier, less money towards, I would say, taking care of the very sick people, which could be preventable, and that helps the economy in general because there's going to be more money available for those people who are generally sick, even though they're trying. That's a very important thing that I think everyone should understand.
Yeah, and unfortunately, again, on the systemic level, there were some misaligned incentives here, right? Yeah. So we look at, first of all, insurance companies today largely own the providers, the hospitals, the physicians, and therefore, when people are sick and utilizing those services, the insurance companies are paying themselves, and they can build the profit margin into that. A secondary problem we have had here in the U.S., right, is one of the changes that was made in the insurance system was capping the profits that insurance companies could make. Sounds good, right? Yeah. But the way they did it was they set it as a percentage of the revenue, right? The revenue that they're collecting, right? So that maybe unintentionally, maybe intentionally, however you want to look at it, now incentivizes the insurance company to just keep raising costs and keep having more money put into the system. So now that fixed percentage that they can take out of the premiums becomes larger and larger. Yeah. And these, again, are some of the systemic issues that we're battling against. I've said many times now that the healthcare system works great for everyone except the patients and the doctors. Mm-hmm. And that's a fundamental problem that we need to tackle. Right. And, again, that's on the larger level. As an individual, when I talk to people, I always tell them, don't wait for that to happen. Hopefully it will happen. Hopefully some of the political things that are going on, the system is going to ultimately change. Mm-hmm. But we as individuals have the power to start making these changes. And we need to start making these changes. And again, voting with your wallet, voting with your dollars is going to be very powerful. And then as the system sees these things changing, they'll start to change in response to it.
I agree. I've seen a big decrease in the amount of doctors that have their own clinic, unfortunately, because of that. Because there has been, I would say, not a financial incentive to start a clinic on that way. And it gets really complicated for the doctor itself, and then it just leads to them to go to the big hospitals. That has become the norm today, unfortunately. However, they do not have the opportunity to take care of the patient, as I mentioned, for about 15 minutes or even less than that, which is really sad, I would say. You mentioned the 12 deadliest health myths in your book, and you highlighted a very key point that I would like to touch on. And why do doctors also believe those myths? Because weren't they supposed to be the ones who actually debunk those myths to the patient?
Yeah, so this really gets back again to the educational system, right? And two aspects of it. Number one, obviously doctors can't absorb all of the information that's out there about health, right?
Yeah, we're not
It's
sponges.
an overwhelming amount. And so there is some bias that goes into what information gets presented to doctors. And because the pharmaceutical company has taken such a prominent role at the center of the healthcare system, right, they have a lot of influence over this. And doctors simply don't get presented the alternative information. There has also been a push in medicine, right? And this gets back to the earlier thing we were just talking about doctors, being their own bosses,
Yes.
being independent, right? And that kind of independent thinking has been very much discouraged in the medical educational
I agree.
process, right? It has all become about following the guidelines. Don't question the guidelines, and this also gets back to doctors being simply too busy, right? It's easier if you just have a checklist of, look at this, this, and this, and prescribe this, this, and this, right? And that can be done very quickly and efficiently.
Yes.
But ultimately, it may not be in the best interest of the patient, and it may not be in your best interest as a physician. But doctors are oftentimes too just overwhelmed with the number of sick people that they need to take care of that they don't even have the time to step back and think about that.
Yeah, I see that very, very often, as I mentioned on my shadowing experiences. But I also had an opportunity from a doctor that actually had his own practice. And it is a whole different thing. He has time. He's his own boss, even though he shares the ownership of the clinic with other people that he knows. But it's a whole different thing. He cares about the patient. He has time to put in the work with the patient specifically, and even with the new patient, which is an even longer discussion with them about their health. They have a whole center of blood tests, blood panels, and all of that to see if their health is really doing well, because that's a very important thing to know. First off, your patient. It's not just the blood test for LDL, for example, as you mentioned. It's a lot more than that. It's a whole context, holistically, how to know if their health is in place. So what is your advice for future doctors to not fall upon those myths?
Yeah, so the first thing I would encourage future doctors is be more curious and question things, right? Don't just accept things that you're told as the absolute truth, right? And again, an obvious one for me now, but it wasn't apparent then, is, cholesterol is the cause of heart disease. That was an unquestionable truth when I went through medical school. And it didn't even really occur to me, to be honest, to think about, well, is there alternative information around this? Are there alternative viewpoints around this? But being more curious, questioning things from the beginning is very important. And then that independent thinking, right, becomes very important as well. And thinking outside the box, right? Is there a different way for me to structure my career? Can I start my own practice as opposed to go and work for someone who's now going to be able to dictate the way that I practice medicine? These are things that I definitely encourage young doctors to do. I acknowledge it's very difficult, right? Again, there are lots of things that are set up structurally to make that difficult for physicians to do, but we can do it. There are examples of it. I hope that, I can be an example for young physicians, right, how I've been able to do this, and just partnering with, right?
Yeah.
Maybe you can't, set up your own practice right out of medical school, right? But can you find a physician like myself, like others who have done this, right, to partner with, to go be their employee at least, as opposed, to an employee of an insurance company or, a big hospital system that isn't going to allow you to practice medicine in this way.
Yeah, I feel the environment has been put physicians in a very, very hard time to think independently by themselves because they get into very high amounts of debt, especially now. It's getting a lot expensive, medical school, very expensive. then you also have a lot of studying. You don't have time to do that, to do all of that things in a row. For example, let's say me doing the podcast and all that stuff at the same time while I was studying for medical school. It's a lot of stuff to remember. It's a lot of names to remember, a lot of drugs to remember during medical school. You study a lot of that, and it's really complicated for you, especially because when you're going through med school, that's when you're going to become a doctor. So if you do those outside things and you don't dedicate that time to study, even though, let's say, maybe not the most important thing for you to become a cardiologist, to become a primary care physician, that is part of you to be a doctor. You have to pass those boards tests, and it gets really frustrating, I would say. And then the doctor ends up not thinking about himself and just thinking this is the truth, because that's what he's taught to, and that's how he's going to pass the board exams, thinking this as truth, which is really sad. I really think we should change that environment for physicians, because it has become much harder for physicians to become to think independently, I would say. It's really sad.
Yeah, and this is where as I think about, what a future physician is going to look like, right? And I think about how we can leverage some technologies that may seem a little scary at first to many doctors, right? And many doctors, are resistant to things like AI coming into their practice. Yeah. But the smart way for physicians to start to leverage this is to think about how it can be used to give me back more of my time, right? And these algorithmic things that we do, right, those can be done much more efficiently by something like AI.
Yeah.
And this can be a plus or a minus, right? Because if you're a physician and the only thing you're really doing, right, is, taking in a set of symptoms, looking at blood work, and then figuring out a medication to prescribe, right? That's going to be able to be done much more efficiently by technologies like AI.
Because it's just decorating the information, right?
Exactly. Yeah. And so, again, many doctors think about that and they get scared. They're like, well, I'm going to be replaced. There's going to be nothing for me to do. But how I would encourage doctors and future doctors to think about that is, great, that's going to offload that part of my job, right? And now I can spend that time focusing on those higher level issues that the computer isn't able to do well.
And which is going to turn you unique by yourself.
Exactly.
From your knowledge.
Yeah. And so, I think ultimately it can be a positive. But again, we as doctors have to take control of that. Because if it's someone else that is thinking about, how to replace us, right, with AI that's going to be a lot less expensive to them, they're going to do that. And I think the successful doctor in the future is going to be able to, leverage that for their benefit, build on top of it, be able to have those higher level discussions with patients, and to be able to really think about those complex issues that, start to get lost. Right? There's still a very human element to this that is going to be the most essential sort of, tool that a doctor's going to have available to them in the future, being able to build on top of that algorithmic stuff that the AI can be doing.
I agree. AI is a really great tool for doctors as a leverage of time, and I think this is what they lack the most, and which is a really good thing. Also, your book is 4 years old. So has anything changed in your mind from what you've put in your book? Because that normally happens with many doctors. For example, you say, let's say Paul Saladino, when he talked about the carnivore code, he changed a little bit, turned into more animal-based diet, let's say, and now he has a different perspective of carbohydrates within his idea. Has anything changed from your book itself? And would you add anything in your book?
Yeah, so I'm pretty proud, I guess I would say, of the way that the book has held up.
It's
and
really
I
simple,
think
really good for patients
Yeah.
to understand in an easy way.
Yeah, I think as it lays out those sort of basic principles, those first principles. It gives people options, right? I don't say this is the one diet, right, that you need to eat. And so in that sense, it has held up well. Now I am working on my second book. It's going to be coming out July of 2026. And once this podcast gets released, it's going to be available for pre-order. It's called Stay Off My Kitchen Table. And the way that I explain it to people is stay off my operating table was kind of the how you do this, right? It was the roadmap. Stay off my kitchen table is going to go a little deeper into the why this is what you should be doing. We're going to really be focusing on things like nutrient density and bioavailability as the guide that leads you to these are the things that you should be doing to improve your health. So again, I don't think it's necessarily a change. There really isn't a whole lot in the first book that I would change. I think it has held up well and will continue to hold up well because it's focused on those core tenets, those first principles of metabolic health as the key to good overall health.
One thing that I've noticed with many, many doctors is that most of them are not good at following their own advice. Most of them just tell the patient to do this, but he himself does not do that. And the patient itself lose credibility for that. The doctor itself lose credibility for that patient. What would you say for doctors, even though with lack of time, can be on top of their health too?
Yeah, no, I agree that it's essential, right? Doctors need to be high performers, and being in good health, good metabolic health is key to that. I think back to, how I functioned as a physician, right? As a morbidly obese, pre-diabetic, physician and surgeon versus today, right? And it's a world of difference, right? And despite the fact that I'm, 10 years older now, right, I find myself with more energy to do all of the things that I'm doing, right? Continue to work as a heart surgeon, run a private practice, right? And the business behind that, do podcasts, write books, right? All of this stuff. I honestly don't think I could have done it physically and mentally when I was metabolically unhealthy. So I think the first thing doctors need to recognize is the importance of this, right? And it's hard to explain to people sometimes, right, how much different it is. Not only the physical aspects, but the mental aspects of being metabolically healthy. What I have ultimately found, though, is that it is easier. It is more time efficient to do things this way, to live a metabolically healthy life than if you're not doing that, right? And just simple things like, today as a metabolically healthy person, as, I'm not insulin resistant, and it's easy for me to eat just once a day, right? Versus being hungry every 3 to 4 hours, right? And I used to, it used to be a big deal to me, right? I'm going into this operation. I'm going to be in there. What am I going to eat before? What am I going to eat after, right? Getting sort of hungry and cranky during the cases, right? These were very real issues I needed, I had to face. Or I would come out of the operating room and I'd have, a bunch of patients to see in the office, but I'd have to sneak into my, office and take a nap for 15 minutes to be able to get through this, or drink, 8 cups of coffee a day, right? All of that stuff that I see so many doctors doing.
Yeah, now, which can make you underperform. Which can make you underperform.
Exactly. The ironic thing is, I think back to when I was a morbidly obese, heart surgeon, and no one ever challenged me on it, right? I really didn't have patients. I didn't have colleagues saying, what are you doing? How are you taking care of people? In retrospect, I wish they had, right? Maybe it would have kind of prompted me to address this a little bit earlier. But like I said, I feel much better equipped to do it. And then those are the results that keep me doing it, right?
Yeah.
And I don't want to give anyone the impression that I'm perfect, right? No one is. But what I find these days is when I might do something that's off plan, we'll call it, right? I don't like the term cheat, cheat days, cheat diet, that type of stuff.
I don't
right?
like that either.
But,
yeah.
Occasionally when I go off plan, it's an intentional choice, right? And I know that I can get right back to it, right? That's one of the other advantages about being in good metabolic health.
Yeah.
We do have some flexibility, right? And many of us in the space talk about, metabolic flexibility and not, you don't have to be perfect at this to get the outcomes. The more metabolically healthy you are, maybe the more latitude that you might have for those things. And it's always a balancing act, right, when you're talking to people, because it can, if you're doing these things unintentionally, what I find, right, that is when you get into trouble, right? Because someone who's maybe earlier in this journey and maybe they haven't completely reversed their metabolic disease and they think, okay, well, I can have a little bit of off-plan stuff. And then it becomes this cascade, and now they're, a couple of weeks later, and they've been completely off, and they've really set back things. Whereas if I make the intentional choice that, okay, for this meal, for whatever reason, I'm going to eat off plan, but then it's right back on plan, the next meal, that is how you can effectively kind of manage yourself and get the results that you're looking for.
Yeah, I totally understand. And also one thing that comes to my mind, and that's when I wanted to pursue medicine, but I was suffering with Hashimoto's, for example. My idea is, how am I going to take care of someone if I cannot take care of myself? That's a very important thing that every physician should be thinking of, I believe. And that's going to make a whole lot of change, because the more, the healthier you are, the more you can do, and the better you can perform for the health of that patient. Yeah. And a lot of people hear this podcast, agree with what we say 100%, also in your clinic, for example, but most of them will not apply what we're learning here and what we are teaching them in that case to become more metabolically healthy. So why don't they listen?
Well, I think ultimately, it comes down to how we communicate these things to patients, right? I don't find it effective to tell them what to do. Right?
Yeah.
Even though many people think that's what they want, right? They come to the doctor and they're just like, just tell me what to do. But really what they want is to understand why they need to do that. Yeah. And some of the things that I have found as key to people's success is that they understand why they're doing it, right? And really why, there's a paradigm that people talk about, right? Where you ask someone, why do you want to do this, right? And they give you an answer, but then you have to keep asking them why, right?
Yeah.
Why do you want to do this? I want to lose weight. Well, why do you want to lose weight, right? And then they think about that. And you do this, and by the time you get to like the fourth or fifth why, they really now, this is their motivating factor, right? Because ultimately, I tell people that the concept that I lay out in the book, for instance, and the concepts of how to be metabolically healthy, they're simple concepts, but they're not easy to implement, especially in our world today. And so ultimately what this comes down to is the motivation of why you're doing this has to be more powerful than the ease of just doing what everyone else is doing and becoming metabolically unhealthy. And so a lot of the work that I and my coaches and my team end up doing with people is getting them to understand why they're doing it, right? And then getting them to understand why this is the right path and why this can benefit them. And that's when we get the success. That's when it really becomes a lifestyle change as opposed to a diet. They're focused. I talk a lot about borrowing from Scott Adams, right? Systems versus goals. I mentioned this in the book. And those are the things that get the long-term success that we see.
I agree. And many people forget motivation, the word itself, motivation, is motive in action. And as you know, motivation is totally linked with dopamine, which gives you the desire, the drive to do something. So if you don't understand the motive of that action, which is asking why, you will not be able to perform that. So same thing, I also do the exact same thing for other things that I don't want to do. For example, let's say study for the MCAT and all of that. It's really boring. It's really boring, some stuff. For example, I don't like physics at all, even though it's important to learn medicine, to learn the electromagnetic fields and all of that. If you don't like it, you need to understand the motive behind it. Why are you studying? What can that make you a better doctor? That's a very important thing that we should be asking. And it's really good that you mentioned that, because future doctors I think they're also forgetting about the psychology side of medicine, how you teach them to perform that way. Because many doctors are good just like you, but they do not know how to trigger that idea on the patient's mind. For example, they will say, okay, but you have to eat more animal products, eat foods that can be processed, collected, and done in the farmhouse, for example, like cheese, dairy, maybe some rice, occasionally fruits, etc. But they will not do it. Why? Because they do not know the motive from that action. They do not know the reason behind this action that he's taking, which is going completely off the way from what the average society is doing. And I think that's a very important thing for them to understand. I really like that approach. And I think every doctor should understand that. Anyways, thank you so much, Dr. Philip Ovadia. It was amazing talking with you. I really appreciate from you coming here from St. Pete to Tampa to talk to me about this case, talking about your book, and also about the vaccines, which I think is a very important topic that many people wanted to understand, that you did not have the opportunity to talk in your book because of the lack of future, I would say, prospective changes regarding the COVID vaccine and also the virus itself. And I would like to gift you. So I have a little gift here that I found for you. It's a little heart that you can put on your office. I hope you like it. And you can also put some flowers on it or some plants towards it.
We'll
yeah.
unbox it for people, but that's awesome. Thank you.
So white matches with everything, so that's
Beautiful.
What I thought, yeah.
Yeah, that will be a perfect model. Pretty good anatomic representation. We even got the left anterior descending vessel coming down the front here. Love it. Thank you very much.
Thank you very much. It was amazing talking with you.
Thank you.
This was the Thrive Talk podcast number 14. It was a pleasure talking with you. Thank you so much. Stay tuned for the next podcast.